Of course. So thanks everybody for joining us today. I'm really happy to have Dr. Todd Dardas here from University of Washington, who's going to be talking to us about an interesting topic and something that's probably, something we all kind of have a superficial knowledge about, but definitely, knowing how to assess the risks for our patients in heart failure is very important and definitely testable material for our advanced heart failure and transplant cardiology boards for those that are going to take those at some point in the future. So Dr. Dardas, thank you again so much for joining and speaking with us today, and really looking forward to your talk.
Great. Thank you, Dr. Beasley. As you said, I'm Todd Dardas at the University of Washington. I also, some of you may have heard, I also work at Up to Date, where I'm one of the cardiology deputy editors. And let's get started. So disclosures, I have no relationships with industry. I do have an Intermax grant for risk modeling, and I've been involved in risk modeling and risk assessment research for a long time. So I guess that's an academic bias that I may have here. So the task here is to know how to assess a risk factor or model, restated from the exact goals I was giving, how to review some, or how to be critical about some of the commonly used risk factors and models in heart failure, and to understand how risk estimates relate to the practice of advanced heart failure. So this is a tall order. As you all know, heart failure is a common condition, and we have a lot of advanced therapies, and this is kind of a perfect storm for there to be a lot of information published about prognosis and about estimation of risk. And it can be very hard to know, which thing to choose. If we had a sign or a factor or a model or something that told us all what to do, I wouldn't have to give this talk because it would be clear what to do. However, it is very unclear what to do. When I prepared for this talk, I did a PubMed search, and there's over 55,000 papers in PubMed that come up when you search for heart failure and risk stratification. So we're going to make a small dent in that today. But what is the goal? Like, why do we even care about risk stratification? Well, I think ultimately we're trying to compare our patient's risk to the benefits of a therapy. So if we have an untreated patient, they just go along the way they are, we want to know how likely is it that something bad is going to happen to them, usually death. Disability is kind of an uncharted territory for risk prediction, and we'll talk about that a little bit too. But we want to know, is this therapy going to help this patient? And the best way to know that is basically to see if their survival untreated would be worse than if we offered them a therapy. And, we know of a lot of risk factors, and we kind of bin them in our minds. I think we sort of think that this is what's happening, that the patients having outcomes here in blue are well separated from the patients who are not having outcomes here in the kind of salmon color. And so we set our thresholds at down the middle here. We decide yay or nay, and we move on, and we bin patients like this. But the reality is much more complicated. This is sort of a view of what would kind of be a pretty standard distribution between patients having outcomes or not outcomes that you rarely see published, because it's hard to publish papers when you present this kind of data. But this is actually the reality of what a lot of our risk factors look like. There's a giant amount of overlap. So we have to figure out some way to tell the difference between good risk factors and bad risk factors. So how do we do that? Well, we need to be critical. So just like you might go through a randomized trial with a set of criteria so that you can gain an idea of whether the therapy suggested is going to be beneficial or not, we need to do that with risk factors and risk models. So this is by no means an exhaustive list of what you need to consider, but these are kind of some broad strokes. So at the outset, you'd ask yourself, what information is gained? If someone is telling you about a prognostic model for patients on ECMO, you can probably imagine that you have a pretty good idea of what's going to happen to a patient on ECMO. They have a very high risk of dying. They have a very high risk of complications. Maybe there's some play in there where you could understand something you didn't know by the patient beyond ECMO, but by and large, you know what's going to happen. At the other end of the spectrum, a very low risk patient who has, does not use diuretics, has never been hospitalized, takes all 4 of their heart failure medications at the highest dose, and can still walk 3 miles unencumbered, you're probably not really considering another therapy because they're probably doing pretty well compared to what we have to offer. So again, a risk factor or risk model is not going to be particularly helpful here. I don't need a new biomarker unless that biomarker can see well into the future and, to make some prognosis about that type of patient. So think about the setting in which the information is being offered and whether you're really gaining something. Secondly, is the measure adjusted and unbiased? Again, like when risk factors are studied, they're often presented in isolation. NT-proBNP can divide patients. Exercise testing can divide patients. But the reality is that we use a lot of other things that we understand sort of naturally, like age, creatinine, frailty, how the patient looks, whether they have family support or not, all these other things. And it may seem a little trite to say, but you want your measure to add to that gestalt that, into your clinical experience. That clinical experience and gestalt are not unimportant. So a good risk model or factor should really be adjusted for other things that we already use to understand whether it gives us new information or not. I think someone, maybe Radha, if you could mute your, there we go. Great. And is it unbiased? So just like in a randomized trial, if you study a risk factor in a very restricted population, it may not be generalizable outside of that population. So you need to think about how this risk factor model was studied and whether there are systematic biases in the data that are going to lead it to either look good or not. Now, if you decide you need the information, you decide you have a adjusted unbiased estimator of some risk, so you're doing well. And next is the relationship between risk and the outcome biologically plausible. So down here to the left, you can see these open dots are kind of the most biologically plausible, probably, with things going up and to the right here with risk. Whereas this S-shaped curve and this imposed threshold at 11 on this toy example, these are probably not believable relationships between risk and outcome. We occasionally will see like a U-shaped relationship, which I'll show you in a minute. But if it seems like the relationship is kind of off, or maybe compared at the extremes only, you should be suspicious. And as for thresholds, we'll talk about that a few times in this talk, but these are really for convenience. I think we all know that risk increases linearly, or should in most cases, but that we bend things to have some sort of waypoint to make a decision A or decision B. It's just sort of a naturally human thing to do. Lastly, is the measure validated externally? There are a number of risk models and things that never really get scrutinized with external validation. So we probably want to ignore those. A new risk model in a small number of patients at a single referral center, probably not as interesting as one that is derived from a large multi-center population and validated in a completely different population and has the same diagnostic characteristics in the external population as it had in the sample in which it was created. And to that point, you'll often hear something about overfitting, and there's an example of this here on the right. If our pink data points are fit by some equation in blue here that exactly fits them, when we go to a new data set where the pink points are in a slightly different place, we're going to get very different answers, especially in the range of this large swooping prediction interval here. Whereas the black line here, which is a simple linear regression, is probably a better fit that is more likely to stand up in other populations and avoid the issue of overfitting. So again, these are 4 things that you can look at to be critical. There are many more, and I'm sure you've encountered all those in a randomized trial, and you can kind of apply what you've learned in randomized trials to this exercise exactly. So once we've done all that, what do we get presented with as users of the medical literature? Well, we often get presented with discrimination and calibration. Calibration is an old measurement is being increasingly reported, so I thought I'd cover it here. Discrimination is the AUC or C index, which is a survival version of this, and in machine learning, something they call precision recall. And this is essentially, can the model order things on the basis of the values of the measurement or model according to their rank. So if I use the analogy of banks here, if my model tells me that bank C has more money than bank A, then it's wrong. If it tells me that bank C is the biggest, then bank A, then bank B, it's doing good. So that is essentially discrimination. And when we do that along every value of a marker, it tells us something about whether risk is increasing with increasing values or not. Calibration, which I think is probably more important, is measured by something called the Breer score, calibration large, and calibration slope. And it can tell us exactly what is how much money is in bank C. Let's say it's $80,000. Bank A is $50,000 and bank B is just $20,000. And it does a very good job at telling us exactly how much money is in the bank. And this is especially good for prognosis. We're often interested in an exact prognosis. We don't simply need to know whether someone has higher or lower risk than the next person based on their value. We want to tell the patient you have a 75% chance of dying at 1 year. We want to be accurate when we say that. So that is where calibration really comes in, and I would encourage you to look for that statistic as you review papers. It's also very good and important to have this intact and accurate when you look at expected observed outcomes in, for example, the OPTN, public reporting and transplant center performance. Other measures that you will see are the usual kind of 2x2 tables: sensitivity, specificity, positive predictive value, negative predictive value. Again, in machine learning, we have all these new terms, precision and recall, as well as something called the F1 score. So if you see those, just know that they are slightly different calculations on a 2x2 table. And that's all I'll say about that. Just visually here, here's a discrimination or AUC curve on the left and a calibration curve on the right. And I'll just remind you, this comes from my little toy example here. So you can have factors that really overlap each other, and they can have reasonable fit. Like we would say that AUC of 0.72 is kind of an okay fit when we think of discrimination. But you can see the data that comes from there. You may not be so convinced. And as you can see here in the calibration curve, things are kind of lining up on the line of identity, which suggests that the predictions are relatively accurate. And in fact, absolutely accurate, not just relatively accurate, kind of misspoke there. How about risk models? We've been talking about single factors so far, but a risk model is very similar. We just take a bunch of factors, we give them a weight, we compress them into one number, and then we use that number to calculate all the diagnostic statistics I've just shown you. Risk models often get sort of a bad rap, I think. I would encourage you not to either hold them higher or lower than any other thing that you think is an important risk factor for your patient. Up here in my little table, if someone has a magic score, which is 26, which is kind of an average risk that doesn't suggest a terrible prognosis, but their creatinine is 2.8, you're probably going to have a much different view of them that is not anchored to the risk score. So people say things like risk models can't predict outcomes. I don't think they ever claim to do this. They're always just evaluating some risk of an outcome, just like albumin, any other thing, frailty, any other thing you might want to consider. So they're really just on equal footing with those things. Okay. So how about some common risk factors that we use in advanced heart failure? We'll kind of start at the beginning of a time course in a patient here. I need help is this increasingly common thing we hear that we should be encouraging our referring cardiologists to use so they don't go by the signpost of warning signs in terms of identifying advanced heart failure. It includes these factors here. I think, for most people already on inotropes would already indicate a pretty bad problem, as would end organ dysfunction. Some of these others may be a little more subtle. But I'm really going to focus here on hospitalizations, which is probably one of the best studied ones among these groups. And we think of the number of hospitalizations as being prognostic. So here's data from one of the original validation studies. I believe this is from Canada, where they looked at a population of patients and just plotted their mortality based on the number that they had. And you can see that there's a graded relationship between the number of hospitalizations and the likelihood of dying over the next. Let's think about, are these adjusted? So they do give us some adjusted statistics here, and you can see these are maybe a little less prominent than you might think. For one hospitalization being the reference, if we have 2, we only increase our risk by 20%, and then 3 by 30%. But how does that compare to other things that we might measure? And it compares favorably, and it certainly is significant, but there's many other things that we can consider here that would further stratify risk for this patient. And as you all know, this is how we actually do things. We don't just look at any single risk factor and make a decision. So CKD here, dialysis, of course, all of these are going to change the risk a little bit up or down depending on its presence or absence. So in terms of number of hospitalizations, how well does it stand up? There is information gained, and we know that because the measure continues to be predictive in an adjusted sense. We have some very nice unbiased trials from community populations that suggest that this is all true. It's biologically plausible, and again, it's been externally validated. So number of hospitalizations under critical review, I think, sort of passes a test for being a good risk predictor. All right, so you did your I need help. The patients had 3 hospitalizations, and you want to know more. So you, of course, being an advanced heart failure specialist, order a cardiopulmonary exercise test. And cardiopulmonary exercise testing, as I'm sure you all know at this point in your training, is a common test for us, which has many variables, and many variables calculated even from those variables to give us a sense of what prognosis might be for a patient with advanced heart failure. And you can see here on the right, this is from the Revival registry, which measured an exercise test in about 300 patients. There are only about less than 20 outcomes here that this measured, but you can see that exercise measures do have a pretty high AUC here, the VE-VCO2 slope with an AUC of 0.79, and peak VO2, which we commonly use somewhat less at 0.72. But maybe there's some bias here because these patients were enrolled in this registry. So we want to look somewhere else. So here on the left is some data from the HF Action trial. And you can see here that peak VO2 has an even lower AUC. So does VE-VCO2. But again, this is sort of a selected population, probably a less ill population than a true referral population for advanced heart failure. We can also see here, though, that when we add measures together, like let's say peak VO2 plus the Seattle heart failure model down on the bottom row in the gray table there, you can see that it really adds very little. The Seattle heart failure model by itself is 0.72 and peak VO2 is 0.73. So while it does add some information, it's not a whole lot. So we didn't really learn a whole lot in the sense when we adjusted for variables that we are already aware of. Here's just showing that the calibration is reasonable. So CPET is quite good. I think in modern practice, though, the main limitation of it is that we don't have updated information with modern evidence-based medical therapy or devices, mitral valve therapies, things like that. So we've done our exercise study, and it has shown us that there's an issue, but we're not sure. So maybe we should calculate a risk model. The guidelines actually suggest doing this. I think in 2024, the MAGIC risk model is probably the best one we have. Here are its variables. And it is sort of biologically plausible in terms of risk increases, both increasing score. Here on the right, the red and the greenish boxes line up, which suggests it's relatively well calibrated. And here formally, we can see in a validation cohort that it's also quite well calibrated so that the predictions from it are quite accurate. And again, I'm kind of showing the same thing with a threshold applied. So magic, I think, in 2024 is probably what you want to be looking at. It kind of meets all these four criteria here for a good risk model if you're going to use a risk model. Now, let's say you're considering an LVAD, and here's a newly published, relatively newly published HeartMate 3 risk score, which includes these 6 factors, which I'm sure you've all considered in your own gestalt when evaluating a patient, and kind of quantifies these factors into a score that you can use. And you can see here that the calibration, as measured on the right, amongst these 5 groups, is maybe not that great at 1 year for patients with a relatively low value, and kind of improves with patients for higher predicted survival. And you can also see here that the AUC at 1 year is okay, but not so great at 2 years. It kind of drops. This score has been externally validated. This is a sample of patients from, I believe it's Columbia University, so it's a much smaller group of patients than what it was derived in. So you have to consider that, but you can see here that it really did not discriminate well or calibrate well between their patient population. Of course, you'd want to see larger data set, and one that may not be prone to the biases of the Columbia University Medical Center. So the HeartMate 3 risk is probably pretty good, but not perfect. I'd also like to make the point here that, when you look at these models, there's so many things that we think about when we think about a LVAD, and you want to know whether they were tested in the model or not, to know whether the model is giving you the only things you need to think about, or some that maybe were left out. And here you can see that there's a number of things in here that are probably very important, right? So destination therapy wasn't published in the model. I'm not quite sure why, but it was a significant predictor, actually. And you can see there's 15 other variables here. You might be interested in various measures of right heart failure, which they tested, things like that. These are good places to look. That is in a study of a risk model, to see if those things were tested and whether they came out as important in the setting of all the other factors that were simultaneously tested. So the HeartMate 3 risk score, we definitely want to know, is someone going to benefit from getting an LVAD in? So there's some information to be gained there. Is it adjusted and unbiased? Yeah, all risk models are internally adjusted, but is it unbiased? Maybe because it was validated or rather derived in a randomized trial, it carries some of that bias of the trial conduct in there. Is the relationship biologically plausible? Yes. And is it validated externally? Well, it is, but it didn't do very well. So we kind of need to wait for more data before we start making a lot of decisions, or including this into our multimodal assessment of heart failure risk. All right, I think this is my last one. So predicted heart mass. This has been very popular since it was first studied, and this is the original study, which kind of shows that as the patient is undersized, which is number septile 7 here, versus oversized, which is septile 1, that risk sort of has a U-shaped relationship, probably better seen here. This is from a validation study of a UK biobank heart mass score estimator, which correlates very strongly with the usual one we use, which is from MESA. And you can see here that as patients are undersized and oversized, we get this kind of U-shaped relationship where there's a sweet spot in the middle. And here, another look at this using something called a spline, which attempts to kind of tell you what the risk is along the spectrum of all the values here. You can see that it has this kind of U-shaped relationship. But this slide I included really to get you to think about what is the information gained here. The predicted heart mass has 4 variables, one of which is weight already. And we're already using weight matching before this came out. So it is probably much better than weight, but I don't know how much better. You can see here in this gray box where most of the matches in the transplant system occur, the confidence intervals, cross a hazard ratio of 1, suggesting that it may not be adding a whole lot of information there. And that where it really adds the most information is at the extremes, which I think most of you would try to avoid in practice already. Here, just showing that in an absolute sense, these curves aren't splayed out over the entirety of this graph, which is limited, as you note here on the left, from 50 to 100%. So in an absolute sense, we gained a little bit, and we almost certainly gained something, but it's not a whole lot in terms of absolute survival by using predicted heart mass. So, is there information gained? I'm not totally sure, but it probably is the best thing to use. And is the measurement adjusted and unbiased? Difficult to know. We've already sized all these patients as best we can before we ever thought about predicted heart mass. So we're kind of looking at a highly selected data set here. However, there are a lot of external validation studies, and it certainly is biologically plausible. I'll just briefly mention that all your programs will be measured and publicly reported by UNOS, and a risk model is used to do that. And that risk model could use some improvement and be more accurate and so forth, but just know that this is adjusting by a risk model is something that can and is done to measure transplant program performance. Okay. So we're wrapping up here, but the challenge here is to kind of find this golden window for referral for advanced heart failure therapies at this sort of perfect time. I think it's arguable whether risk models and specific risk factors really help with this a whole lot. One avenue you could take here is that if you're worried about the patient, you just see them more, you talk to them more, you educate them, and you choose a therapy that they are amenable to when it seems like they are a good candidate for it. I think all of these risk factors and models I've been talking about kind of go into this equation. It's hard to say that any single one influences your decision over any other single factor. And I'm sure as you've presented at your meetings, you've all understood this, but I think it's just important to note that we get a little bit excited about these risk factors, but really they're part of this multimodal assessment. And so, risk can be nebulous, right? So when you're at these meetings, I'm sure you hear all sorts of comments from people who have opinions about this. Risk model isn't going to manage my patient, things like this. And it is very nebulous. I would encourage you to take a look at the book by Tetlock and Gardner called Super Forecasting if you want to read more about this. But, we were evolved to respond to danger in the environment, and we had a choice. We could either stay and fight or we could run away, which is a very binary decision. And, most people, when confronted with a lion in the grass, are not going to say, oh, it's about a 30% chance I'm going to get attacked by that lion. I'm going to wait it out and do some more analysis here. So we are not sort of evolved to consider risk along the spectrum very well. The time course of risk, I think, is also an interesting thing to think about. I don't think most people can think beyond much of a year. So when you're giving prognosis, think about giving short-term prognosis and looking at models and risk factors that evaluate that. And again, thresholds, I can't say it enough. We use these for convenience, but they're really not, there really is no biologic plausibility to an absolute threshold. So how do we evaluate these patients? Use everything available, even a risk model. Don't ignore patients with elevated risk, certainly. I think we can say that about risk factors and models. If something says there's a problem, you should heed that warning sign and follow the patient up more closely, do more testing, optimize everything you can. And ultimately, we're just asking ourselves, is it reasonable that the benefits of the therapy exceed the risks? So what are our main advanced heart failure therapies? Well, they are transplantation here on the left with the kind of golden bar for the most recent experience from the ISHLT registry, and here from the Momentum trial, LVAD survival at 2 years. So what we need to do is try to be reasonably certain that the patient is likely to have a better survival with transplant or LVAD compared to their current medical therapy. And I'll say for all these, the research and all the available information on this, I often find myself going back to the rematch trial and looking at the medical therapy arm and the LV assist device arm, but especially the medical therapy arm. If I'm sort of convinced that I've done everything I could to improve prognosis, and I'm probably somewhere along the medical therapy arm. I think this has probably gotten a little better. Although, 72 and 65% of these patients were on inotropes in this trial. So, certainly on the setting of inotropes, there's a much worse prognosis. But I find myself coming back to this a lot and explaining this type of prognostic information to patients. So in conclusion, risk factors and models only add to the assessment in the way that everything else adds to the assessment of risk. There's no one factor, there's no one thing that is going to tell you exactly what the risk of a patient is. So use everything. Be critical of new factors and models. Take a systematic approach when you review these to see if they add up in your own mind and give you the certainty you need to give the patient a prognosis. And, it's going to be a big challenge for you all. Here's this PubMed search. So 55,000 papers. I think we've talked about maybe 15. So there's a lot of work for you all to do out there in applying these skills, and I wish you luck. And I will close with that. And if you want a copy of all of these articles, or at least their PubMed page, you can scan the QR code here. And this is my email if you have any questions or comments you want to send me. And with that, I'll take some questions if you have any.
Thanks, Dr. Dardas. Appreciate the talk. Such a great deep dive into this topic. Fantastic job. We just have a few people left on the call. A bunch of people have jumped off already as we've passed the top of the hour. But for those of us still on the call, anybody have any questions for Dr. Dardas before we let him wrap up?
Hi, Dr. Dardas. This is more of a statistical, thank you for this excellent talk. This is more of a statistical question in the sense, when you're evaluating spline models, like how many knots kind of do you think about when you try to evaluate, because there's too many knots also is overfitting a model. So in terms of continuous variable analysis, when you're reviewing a model, what are you trying to look for?
Yeah. So I'm sorry I could not quite catch your name, but thank you for the question. The question is about, when we try to make predictions, and we're not using a threshold, we can use kind of micro thresholds along the predictor. So here with predicted heart mass, there's a bunch of, I think what they've done here is created a bunch of things to kind of smooth over what's going on. But the data will kind of have to tell you, and a lot of it has to do with biologic plausibility. When I do analyses like this, I usually just use 5 and try to get at the extremes of the data and see if there's some weird relationship that my linear model is not capturing. And if there is, I have more work to do to go in and figure out, how to handle that and how many knots, as the question asker is suggesting, which is how many dots along this continuous thing do I pick? So I don't think that's a firm answer, but I think you have to let the data tell you to some degree what the relationship is.
Any other questions from the group? Well, with that, I guess then we'll wrap up. So, Dardas, again, thank you so much for the time today and the fantastic talk, and really grateful for you to have you join us.
Yeah, thank you so much for inviting me, and everyone have a good day.
Bye-bye.
Bye.